Good morning and welcome to Pediatric Grand Round. This is 7:30 and time to start our Grand Rounds. Just a quick reminder that we will not have Grand Rounds next week because of Thanksgiving holiday. It's my great pleasure to introduce this morning's Grand Round speaker, Dr. Naila Eskaname, who is an assistant professor in the Division of Pediatric Endocrinology in the Department of Pediatrics here at UT Health San Antonio. Naila is a native of South Texas and was born and raised on the Texas-Mexico border. She earned her bachelor's degree from Texas A&M University in College Station. Then she completed her medical school at UAG in Guadalajara, Mexico, and her pediatric residency at the University of Illinois, Chicago. She completed her pediatric endocrinology here at UT Health San Antonio. She joined the Division of Pediatric Endocrinology in 2017. Her research interests include childhood obesity and type 2 diabetes. She enjoys mentoring medical students, residents, and fellows in all aspects of pediatric endocrine and diabetics care and has an active portfolio of clinical research projects. She currently serves on the board as well as medical director of Project Power, a diabetic prevention camp that works in conjunction with American Diabetic Association and other community partners to prevent youth onset type 2 diabetes. She serves on the Community Engagement Council for the Equitable Health in San Antonio. Dr. Eskaname, thank you very much for accepting our invitation. The floor is yours.
Good morning, everyone. Thank you so much for allowing me to talk about an area. It's actually one of the reasons I entered endocrinology is the prevention of type 2 diabetes. We are in a new era of a new option for obesity management and type 2 diabetes management. So that's why I titled, and because I'm a Taylor Swift fan, in our GLP-1 era. I have nothing to disclose. So my objectives today are to kind of view it in the lens of not as a subspecialist necessarily, but more as a general practitioner to help define childhood and adolescent obesity, to help identify national and regional trends in obesity prevalence among children and adolescents, to discuss the health implications and long-term consequences of childhood adolescent obesity, and to develop an understanding of the role this GLP-1 receptor agonists play, their mechanism of action, when are they clinically indicated, and some of the therapeutic benefits, but also some of the challenges we have with these medications. I'm going to start with the poll. Can y'all see the QR code?
No, we don't. How about others? I don't see it on my screen. Yeah, I see your question, but I don't see a QR. Yeah, I see the questions.
So the panel's not showing up.
Questions and the options, but I don't see the QR code. It says hide the QR pan.
Seems like it's hiding it, but it shouldn't appear like this. So I'll just go ahead and talk through it.
Okay, that's fine.
And then see if there's on the next couple of slides, if it hopefully reappears. So as of 2017 and 2018, how many children and adolescents in the US are classified as being obese?
People can put their answers in the chat box, and if or they can shout out, basically. Dr. Reyes says 27%. Dr. Scott Jones agrees.
So actually the correct answer for the prevalence is 19%. And I'll go to in a little bit more about the epidemiology of it. Hopefully the next question's QR code comes out.
Are you able to advance the slide? Because we're still on the first question.
This one, I'm trying to see if in presenter mode, it kind of disappeared. I might have to exit. Let's see. Oh. Okay. I'm afraid this might happen. It's a feature where it's not showing me the presenter mode at the bottom anymore. Let me see.
Can you no responses yet? Get your, yeah. You might want to share the slides again.
This looks like it might work.
Okay. Yeah, we see the QR code now. Yeah, we see the QR code. Disappeared after that slide.
Goodness, it's something about.
So why don't you go without QR code so we can monitor the chat box? That might be easier.
Easier, okay. Oh my gosh. I think maybe for these, I'll just keep it in not the presenter mode, because when I'm not in presenter mode, it seems to share the QR code.
Okay, that's fine.
And I'll just try to make it as big as I can.
Okay. So this is your second question?
Yes. So the second question is, in Texas, how many children and adolescents in the US are classified as being affected by obesity? So we got several responses. 21. I'll go ahead and show the correct answer now. So 46%, or 21%. So the majority of everybody kind of got that one right. All right. So next question. Weight loss medications should be used as monotherapy for the treatment of childhood obesity. True or false? So yes, the majority of us got it right. So yes, that's false, right? We know that there's a lot of other aspects to the treatment of obesity. All right. So next question. Which of the following medications is not FDA approved for weight loss in pediatric patients with obesity? This is a little bit trickier. I think we have responses. So the correct answer is metformin. Metformin is not FDA approved for the treatment of obesity, even though it's used off label. It's FDA approved for type 2 diabetes in children 10 or older. All of the rest of them are. Next question. Which of the following should be considered in the comprehensive treatment of children and adolescents with obesity? Motivational interviewing, intensive health behavior and lifestyle treatment, weight loss, pharmacotherapy, surgery, all of the above. Yeah, so the correct answer is all of the above. Really, we should kind of be looking at all aspects and kind of stratifying where that patient or child sits in terms of their risk classification. All right, last question. Which of the following are reported side effects of the GLP-1 receptor agonist? Delayed gastric emptying, nausea, vomiting, bloating, pancreatitis. See some already entering in. Yeah, so that's the correct answer. All of the above. All of those are reported side effects of the GLP-1s. So I'm going to go ahead and start. Let's see. Now I can go back into, oops. Oh, okay. There you go. All right. Thank y'all for being patient with those QR codes. Um, so want to start off by kind of defining how we diagnose childhood obesity. So we stratify kids depending on their BMI. So the BMI category is determined by an age and sex specific percentile rather than specific cutoffs like the adults do. So in terms of overweight, it's defined as a BMI at or above the 85th percentile and below the 95th percentile for age and sex. Obesity is defined as at or above the 95th percentile. And severe obesity is defined as a BMI equal to or more than 120th percent above the 95th percentile. So once you get into those kind of higher categories, we just kind of defined it as severe. And then in older adolescents, The adult cutoff of a BMI equal to or greater than 30 can be used to define obesity if it is less than the 95th percentile BMI for age and sex. So the BMI itself really does have some limitations, right? So in looking at how we measure like body composition, the gold standard of determining fat mass and fat-free mass is really like the DEXA scan. And we have other, bioelectrical impedance and other ways. So it's not really kind of taking into consideration necessarily the body composition and fat content. And so it may under or overestimate excess adiposity depending on, certain races, ethnicities, age. Part of my fellowship research project was doing body composition on infants. And we know infants are just all balls of fat. So, it really kind of varies as in the trajectory of our age. So this is a really busy slide, but I really kind of wanted to point out some kind of really important aspects. So one is that pediatricians and primary healthcare providers should be assessing a BMI, right? At their well child visits and using the age and sex specific CDC growth charts to kind of classify, if a child is obese and the severity of the obesity. So if the BMI is greater than the 85th percentile, then we look into kind of stratifying into overweight, obese, or severe obesity categories. And then if they fall into the obesity and severe obesity, well, into any of those three categories, sorry, the next step would be doing a comprehensive evaluation. So depending on their age, looking at a comprehensive history, so a review of system, like social determinants of health, so getting kind of really good social history, physical examination. And when we're classifying kids, I think it's important to kind of recognize that when we discuss this with families, the language that we use is really important because it can be very uncomfortable and stigmatizing to bring this up with families. And so using the kind of like person first language is really important. So saying, instead of saying an obese child, a child with obesity. And so again, looking at once you diagnose them with either overweight, obese, or severe obesity, looking into the history, the mental and behavioral health screening, the social determinants of health, the physical exam, and then depending on their age is doing these kind of annual checks, blood pressure, fasting lipids, fasting plasma glucose, oral glucose tolerance tests, hemoglobin A1C, and ALT. And then if any of these are abnormal, so referring to the AAP, high blood pressure clinical practice guidelines. And then if not, then repeating at every visit. And then if the labs are abnormal, referring to the appendix index and the Bright Futures, which really kind of helps stratify like what the general pediatrician should do next, or primary healthcare provider, in terms of, okay, if these labs are abnormal, how frequently should we recheck? So it really gives a good, the appendix is really nice in terms of kind of knowing when to, refer out or when to maybe repeat, kind of depending on where the levels fall. And then in terms of the treatment, so I'm going to kind of go into more of the treatment aspects of this, but really, what I kind of took away from these guidelines is that really we kind of want to start looking into even just like the weight loss pharmacotherapy or surgery earlier on and not kind of delaying treatment if we know that the severity of the obesity is very high. So I think that's kind of a practice change that I kind of took from these guidelines. So this is an example of a BMI percentile. So if you look at just the percentile itself, it tells you that it's above the 95th percentile, but it doesn't really kind of help you see the trajectory over time. You just kind of see it in the sense that it's been high. So the BMI extended really is helpful, right, to kind of see the progression of the BMI over time. So in this particular patient has always had really kind of severe obesity. And if you look at the most recent point, the BMI is 223 percentile of the 95th percentile. And so in our electronic medical record system, EPIC, it allows you to see the different kind of options of like the BMI extended or the BMI in terms of standard deviations. So I think that's important to kind of to see. So the percentage of US children and adolescents affected by obesity is actually 19%. So that's 14.7 million between the years of 2017 to 2018. That's pretty shocking. And it's increasing among certain populations, so adolescents and non-Hispanic, Black, and Mexican American youth. And it's estimated that if the current trends continue, 57% of children ages 2 to 19 will have obesity by the time they are 35 years of age in 2050. Looking at regionally, so in Texas, the prevalence is 21% of youth ages 10 to 17 have obesity, giving Texas a ranking of 46 among the 50 states. And then kind of looking at local trends. So this was taken from the Witty Body Adventure data, and in conjunction with our Metro Health Department, and looking at the prevalence by zip code. And we've worked a lot with our Metro department and adjudication of type 1 and type 2. So it's really kind of neat what their bioinformatics team can do. But if you look at certain particular zip codes, particularly in like the area of town where we practice on the west side, and certain school districts seem to really have a high prevalence, kind of more of the central southern zip codes of the city. So why is this important? Why does this matter? So we know that children and adolescents with obesity often have a higher prevalence of comorbidities and a greater risk of obesity in adulthood and morbidity and premature death. And the risk of obesity-related comorbidities increases with the age and severity of obesity and varies by race and ethnicities. So some of the obesity-related comorbidities that we screen for are increased intracranial hypertension, obstructive sleep apnea, type 2 diabetes, depression, anxiety, low self-esteem, non-alcoholic fatty liver disease, dyslipidemia, PCOS, Blount's disease, SCFE, and hypertension. So these are all things that we should be screening for as we do our review of systems and our physical exam with our patients. And our institution was very fortunate to be involved in the Today study. And the Today study was a study done many years ago, back in 2005. And there was a study of 10 to 17-year-olds with type 2 diabetes based on 88 criteria for less than 2 years. They had a BMI of greater than 85% and high C-peptide levels above 0.6. And so they didn't have type 1 diabetes. And out of this 699, cohort of youth that were randomized to either metformin plus rosiglitazone, or metformin plus intensive lifestyle intervention, the majority of them failed metformin, so greater than 50% of the cohort. And I think what we've learned now as we've followed, so I became involved, as a, young faculty in the pregnancy outcomes of these now 30-year-olds that were diagnosed as children with type 2 diabetes. And it's really kind of astonishing, like the results. So there's a high rate of microalbuminuria, greater than 60% with hypertension, high rates of hyperlipidemia. And then in pregnancies, 25 of the pregnancies were known outcomes resulted in a miscarriage, 24% resulted in preterm births, and 20% of the infants were born with major congenital anomalies. So we really are recognizing that children that are diagnosed early with youth onset type 2 diabetes really have a very aggressive form of diabetes. And really kind of early of these comorbidities are seen, or early onset of comorbidities are seen. So again, we're talking about kind of like the comprehensive care of the prevention of leading to that state, right? So I'm not going to really focus on, motivational interviewing or intensive health behavior and lifestyle changes or surgery, but really kind of focus in on the pharmacotherapy aspect. So what are the current FDA-approved medications to treat obesity in children? So actually we have these 5 medications that are actually FDA approved, even though, like I mentioned, some medications like metformin are used off-label. So the FDA approved ones include orlistat, which is an intestinal lipase inhibitor that blocks fat absorption from your diet. It's approved for ages 12 and older. One of the real limitations of this is the side effect profile. So steatorrhea, fecal urgency, and flatulence. So most patients don't tolerate it, which is why a lot of people don't prescribe it. We'll go into a little bit more of the GLP-1s. So liraglutide and semaglutide are both subcutaneous injections. They're GLP-1 receptor agonist, and they really help with satiety. They're approved for ages 12 and up. Some of the side effects, and I'll go into more detail about like the GI, but nausea, vomiting, they're contraindicated in patients with MEN, and because of the risk of medullary thyroid cancer or C-cell hyperplasia. And then we have medications that are like combination amphetamine topiramate, which is a central norepinephrine uptake inhibitor, but also non-selectively inhibits serotonin and dopamine uptake. And then topiramate is a carbonic anhydrase inhibitor, and these kind of lessen the hunger and can help manage cravings. Again, they're approved for ages 12 and older. They can cause an elevated blood pressure, dizziness, headache, tremor, dry mouth, stomach ache, cognitive slowing. And then setmelanotide is specifically for patients with genetic forms of obesity. So for melanocortin 4 receptor, they're melanocortin 4 receptor agonists. They are approved for children 6 years and older with, more specific causes of obesity that are genetic. And so that is not something that usually the general practitioner would be prescribing. Usually those are patients that we might see in our clinic. So what is on formulary for Texas Medicaid? Nothing. Texas Medicaid does not cover anti-obesity medications, unfortunately. And Texas state employees, so within our own institution, they dropped the coverage for anti-obesity medications. So it's really hard to get the care that we need for our patients. And this is just an example of the path it takes to get a GLP-1 receptor agonist for a patient with type 2 diabetes. So for type 2 diabetes, they are approved, they're on Medicaid formulary, but the patient has to be 18 or older. And so if they don't, they admittedly deny the request. And so there are other options that you can kind of pathways around it, but this is just to kind of illustrate some of the challenges that we have to really get these medications approved. So what is a GLP-1? So the incretins are hormones released from endocrine cells in the epithelium of the small intestine, so the L cells, in response to food that act on the pancreatic beta cells to regulate insulin secretion. So really in response to food, they release insulin. There's 2 primary incretin hormones in humans. So there's a glucose-dependent insulinotropic polypeptide, GIP, also known as gastric inhibitory peptide, and glucagon-like peptide 1, so the GLP-1. And interestingly, they're not the only good thing that came out of the 80s, including myself, but they were discovered in the 1980s. And the way that they kind of progress into commercial use is that they were able to isolate the DNA of the lizard, the venom of the lizard. So they produce a hormone called exenatide-4 and has a lot of structural similarities to GLP-1, but unlike GLP-1, it doesn't break down quickly. So it remains active in the body for an extended period of time. So it was the perfect candidate for a diabetes drug. So here are some of the incretin analogs that are used in type 2 diabetes. And so we have, the world, now world-known Ozempic, right? So it's a once weekly injection for type 2 diabetes. And actually, it's not FDA approved currently in children, it's adults. That's a typo. Wegovy is approved for weight loss. We have Trulicity, though. Trulicity is approved for type 2 diabetes for kids 10 and older. Victoza also is approved for type 2 diabetes. Byetta, so some of the older GLP-1s that are once daily. Mounjaro, which is tirzepatide, which is kind of a combination drug, is not currently approved for kids less than 18. Same thing for Rybelsus, that oral medication that's a GLP-1. It's not approved for less than 18. So to kind of give an overview, so GLP-1s really kind of work at several target organs. So at the level of the brain and the hypothalamus, it helps promote the feeling of satiety. At the level of the gut, it delays gastric emptying. It also helps decrease blood pressure, and it can increase their thermogenesis and lipolysis in adipose tissue. And then, as I mentioned, it helps in the secretion of insulin from the pancreas. So these are two really kind of pivotal studies that were done in adults. So the first one is the SCALE trial. So this was a 56 weeks randomized placebo-controlled trial aimed to evaluate the efficacy and safety of 3 milligrams of liraglutide injected sub-Q as an adjunct to a reduced calorie diet and increased physical activity for weight management in overweight or obese adults who didn't have diabetes at baseline. And then the second kind of pivotal study was a phase 3 double-blind randomized controlled trial comparing semaglutide with placebo, plus lifestyle changes in overweight or obese adults without diabetes. And these patients were assigned to receive 2.4 milligrams of semaglutide. And so, sorry, the resolution of this is a little blurry, but basically so this chart shows that the proportion of patients who lost at least 5%, more than 10%, and greater than 15% of their baseline body weight. So in the liraglutide group, this was 63% compared to 27%, lost greater than 5% of their body weight. 33% versus 10%, lost greater than 10% of their body weight, and 14% versus 3% lost greater than 15% of their body weight. So these are pretty impressive, and liraglutide is a once weekly injection. The most frequently reported side effects of the liraglutide were mild to moderate nausea and diarrhea. And then for the semaglutide trial in adults, so again, there was comparing semaglutide with placebo and lifestyle changes in overweight and obese adults with diabetes. There were 1,961 participants assigned to receive 2.4 milligrams of semaglutide. And the primary endpoints were the percent change in body weight and a rate reduction of greater than 5% of the body weight. So by week 68, the weight declined more in semaglutide than the placebo group, so 14.9% versus 2.4% in the placebo group. So you see the percent of weight loss from baseline was clinically significant. And again, the side effects were similar in terms of mainly just kind of GI side effects. Some of more of the serious side effects were related to hepatobiliary events. that were reported more often in the semaglutide group. And then kind of moving into the pediatric trials. So again, very similar trials that were done in kids. So with liraglutide, this was a 56-week trial and a 26-week follow-up period. And these were adolescents that were 12 to less than 18 years of age with obesity and a poor response to lifestyle alone. They were assigned to receive either liraglutide or placebo in addition to lifestyle therapy. And the primary endpoint was a change from baseline in the body mass index. And also they were looking at the standard deviation score at week 56. So they had 125 kids in the liraglutide group, 126 in the placebo group. And the percent change in BMI in terms of standard deviation was minus 0.23%. So it was clinically significant. And if you looked at it, in certain groups, there was a reduction in BMI of at least 5% in 51 of the 113 participants. And again, the side effects were very similar in terms of the adult study. So a lot of GI side effects were reported. And then after discontinuation, there wasn't an increase in the BMI standard deviation score from the liraglutide group compared to the placebo. So the kids essentially had started to regain the weight once they came off. And then similar to the adult study, so we've now done, and some of my colleagues have been involved in some of these trials. The once weekly semaglutide in adolescents with obesity is called the STEP Teens trial. And so it's a phase 3 multinational double-blind parallel group randomized placebo-controlled trial to assess the efficacy and safety of semaglutide plus lifestyle intervention compared to just lifestyle intervention alone. And so they recruited 201 adolescents ages 12 to less than 18 with a body mass index in the greater than or equal to the 95th percentile, or in the greater than or equal to the 85th percentile, with at least one related coexisting condition. So some of these kids, if they had like diabetes or high blood pressure, they were still able to be assigned into the semaglutide group. All the participants and their parents received counseling and nutrition on physical activity for the weight loss throughout the trial. And the primary endpoint was the percentage change in BMI from baseline to week 68. So the results showed a reduction in the percent change in the semaglutide group of 16.1 compared to placebo. And then a reduction of body weight of greater than 5% in 73% of the participants. So again, really clinically significant. And actually the placebo group had a modest increase in the percent change of their BMI compared to the semaglutide group. So, and then again, the side effects were very similar in terms of the adult trials and also in the liraglutide. So in kind of a head-to-head comparison, I mean, they both have a very similar profile. So the brand names of these FDA-approved medications are Saxenda for the liraglutide and Wegovy for the semaglutide. They are contraindicated in pregnancy, family history of medullary thyroid cancer, and MEN2 because of the risk of concern of growth in the C cells. And really, this has been mostly in rat studies, so we really haven't seen it much in like the adult and the pediatric studies. But that is something to kind of keep in mind if there's any family history of MTC that's contraindication to its use. And then warnings and any history of acute pancreatitis, gallbladder disease, issues with hypoglycemia. So if they're used concurrently with, insulin or any other medication that can increase the risk of hypoglycemia. And then in kids with acute kidney injury, And in terms of adverse drug reactions, so things that really the, general pediatrician should be looking out for is a lot of the GI stuff. So nausea, diarrhea, vomiting, injection site reactions. And I'm not going to go into like the titration, but again, there are some recommendations in terms of when to discontinue if we're not seeing a clinical response, but really kind of getting kids to a maintenance dose is key. And then a little bit more on the potential side effects. So we talked about pancreatitis, gallbladder disease, hypoglycemia, and the kidney failure. A lot of times there's concerns because the kids are not really eating as much, right? They have early satiety. So if they're not drinking as much, they can get dehydrated. So that's really important, to counsel patients in terms of making sure they're staying really well hydrated. Retinopathy is really starting to come out and studied a little bit more in adults with type 2 diabetes, in terms of like the rapid progression of retinopathy. And then also potential side effects that are listed on both of the medications, depression, thoughts of suicide. And then the delayed gastric emptying and risk for aspiration. I highlighted that because there's actually a new consensus guidelines for adults and children that was put out by the American Society of Anesthesiologists with the GLP-1s to really, for patients that are on the once daily GLP-1s to hold it on the day of the procedure. And for patients that are on weekly dosing, to hold or to consider holding a week prior to the procedure. And this is irrespective of if they're using it for type 2 diabetes or for weight loss. So that kind of poses a challenge for us as endocrinologists too, in terms of management of blood sugars, while these medications are not being used. But it is really important because of the risk for aspiration. So that's kind of where it might start to get a little bit tricky in terms of procedures, but it is really important to counsel the patients about these potential side effects. And then this is a recent article, or it's more of a review by Dr. Drucker, who is really kind of instrumental and helped isolate the exenatide from the lizard, from the Gila monster. So one of the things that the ones that are in gray are kind of the things that we know, right? So nausea, diarrhea, constipation, vomiting, reduced bowel motility, and, the question of potential like ileus, retained gastric content, aspiration, AKI. Again, these patients can get dehydrated because if they're not eating because of the satiety, they might also not be drinking as much. And so that can lead to dehydration and AKI. And then this kind of risk of gallbladder disease, and those are obviously more serious that were reported in both in a lot of the adult studies. And then here, I think this the retinopathy, increased risk for pancreatitis and cancers, really kind of need to be explored and studied much more. And there's a lot of ongoing trials in adults that are really looking into this a lot more closely. So I wanted to provide the audience with some of the resources. We have a really great multidisciplinary team in our clinic. We have an amazing social worker and nutritionist. And so, but sometimes, it might seem out of our capacity to provide the lifestyle interventions that we need for our patients. So it takes a village. So really kind of knowing what resources we have in our community. So the HEB, the Healthy Corner stores, actually are just like convenience stores, gas stations that have produce and non-processed foods that accept SNAP. The HEB nutrition services, I thought it was really amazing to actually go shopping with you and to provide kind of good healthy choices. and some of the other counseling services that accept a lot of the insurances that we see. And then in terms of just food safety, so I just wanted to kind of provide a list of resources that our wonderful staff got together for me and shared. And then some of the exercise resources, because really, it's not just about using the pharmacological intervention. It's also to be able to provide the resources so that patients can also continue to exercise to build up muscle mass. One of the concerns that's also kind of come up is that in patients with like sarcopenic obesity, in other words, kind of what you see in a more the adult population is that, with age, the muscle mass declines. And so when they have these rapid weight loss, they're also losing additional muscle mass. So it's really important to counsel patients. They still need to, follow a good, healthy exercise regimen, build that muscle mass. So when we're thinking about things like body composition, they're also incorporating that really important aspect. And so here are some of the resources that we have for our patients. And then also the mental health aspect, right? We talked about how stigmatizing obesity and just addressing it can be, but then also with the weight loss, what does that mean? Is that some kids get really disappointed if they're not seeing the change in their weight. So just being able to kind of provide some support in a really kind of comprehensive way. So this is my other baby. So Dr. Reyes and one of our previous research coordinators really were instrumental in developing what we now call as Project Power, was previously called Camp Power Up. And so this is a camp, this was a vision that they saw in terms of really trying to prevent the development of type 2 diabetes in youth, and really kind of targeting high-risk individuals that were already kind of meeting the BMI criteria, but also had a first-degree relative with type 2 diabetes and other comorbidities. And so this kind of lifestyle intervention, in addition to nutritional education, has been an ongoing project, and it actually has kind of exceeded our expectations and now been taken by the ADA as a national model. And so if you go on the ADA website, you will see now Project Power for adults. And so it all was grassroots from our endocrine team. So I'm really proud of it. I'm proud that we've been able to do really fun things. We take the kids to the Witty. Last year we gave them bikes that were all donated by community partners. We've had, the local soccer organizations come in and teach, the kids different things just to kind of make, it not so stigmatizing in a group with a lot of peers that are kind of going through the same thing. So I want to thank everyone for your attention. My son, my other babies in his dino era right now.
Thank you, Dr. Eskanami, for that wonderful overview of obesity management, especially the GLP-1 receptor agonist. There are already 3 questions in the chat box. The first one is, what is the rate of obesity recurrence when GLP-1 receptor agonist is discontinued? So how often does it recur after you discontinue the medication?
So I don't think we really fully know yet. Dr. Lynch, you're on the call, and I know you're kind of doing some of these extension studies. I don't know if you could speak to that. I don't know if we have enough literature right now to kind of see how many kids, once they come off, will go.
So by the time Dr. Lynch comes on, there is a second half.
I don't think we know. I think that's the answer. We're doing the STEP team. Actually, we're part of Dr. Lynch is one of the PIs for the extension to the STEP teams. And so we're kind of looking at the long-term outcomes of the original cohort, but also enrolling new patients on it. And so I think that's going to provide us more information of how many kids are regaining the weight once they come off? And is this going to be a long-term medication that they're not going to need to continue on?
The second half of the question are reasons for discontinuing these medication. What are the indications for discontinuing these medications?
Yeah, so some of the indications, and I kind of touched on this a little bit on one of the slides, was a failure to see a change in the BMI. So if there hasn't decreased by greater than 1% from baseline after you're already on a maintenance dose. So you really have to get to the escalation of the dose. And that can be challenging. That poses a challenge for us because, we have limited availability sometimes with our appointments. And so we can't be bringing patients in necessarily every month. And so if we see this expanding, it would be kind of having to be a dedicated way to do that, to make sure that we're seeing the change from baseline. If they're not kind of achieving that, reduction in BMI.
The other question, sort of request from Dr. Cortez, can these resources, the links you provided for exercise and other resources, emailed to the faculty? And the other one is, this would be useful for AVS in EPIC. And I don't know what AVS stands for, but I think if you provide these links on EPIC, this would be helpful.
Yeah, I can definitely do that in the after visits. I mean, like in the patient instructions.
There's a question, a comment from Dr. Williams. Those not specialists were supposed to code excessive weight gain instead of obesity and then code the BMI. Now that it is not an option, so is it correct and sufficient for non-endo to code the three categories like over 120%, etc.?
Yeah, they do. And the AAP actually has some really nice guidelines in terms of coding obesity for the general practitioner. So, I mean, I think I didn't dive into that and I'm not as familiar. I think that's one of the things that we really can work to improve within our own division of how we code this. But the AP actually has some really nice guidelines in how to code for the general practitioner.
Thank you. Any other questions, comments for Dr. Eskaname? So just a reminder that we do not have grand rounds next Friday because of Thanksgiving holiday. We'll see you in 2 weeks from today for the next grand round. So thank you all for attending this morning's grand round. Thank you, Dr. Eskaname, for that wonderful presentation on obesity in teens and young adults. Thank you all for attending this morning's grand round, and we'll see you at faculty meeting very soon. Thank you.